Hello everyone and welcome to tonight's Coronavirus COVID-19 Rural and Remote Response webinar, brought to you by Rural Doctors Association of Australia and the Australian College of Rural and Remote Medicine. Thank you for all that have joined us and welcome to colleagues right across Australia. I'd like to kick off tonight by acknowledging the Indigenous owners of the land in which we meet, acknowledge their connection to country and their elders and leaders past, present and emerging, and also welcome and acknowledge any Aboriginal and Torres Strait Islander people that are joining us tonight on this webinar right across Australia. This is our second webinar in the COVID-19 Rural and Remote Response series, and last week's webinar kicked off with Dr. Norman Swan and a great panel, and it was a really good start to our series, so we're hoping that this will work quite well for us tonight. If you're new to Redback Connect, you can post questions to us directly and we can moderate those questions. Just click on the blue hand icon at the top of the screen and send through your questions. We'll try to get through as many questions as we can. If we don't get to your question, that's fine. We will try and address it and put the answer in our COVID-19 bulletin that comes out each week. So our panel tonight consists of Minister for Regional Health and Regional Communications and Local Government, the Honourable Mark Coulton, the Deputy Chief Medical Officer to the Commonwealth Department of Health, Dr. Nick Coatsworth, Rural Doctors Association of Tasmania President and Chair of the ACRRRM Council, Dr. Eve Merfield. And of course, ever in the background, we have ACRRRM President, Dr. Ewan McPhee, and RDAT President, Dr. John Hall, who are here to answer questions should questions arise. So to kick us off, we will go to the Minister for Regional Health and Communications and Local Government, Honourable Mark Coulton, who I'll invite to have a few words, and we'll get to questions from the Minister before we look at going on to a chat from Nick Coatsworth. We'll have questions towards the end, so don't feel that your questions won't get answered. We'll try and get to as many questions as we can. So I'd invite you to say a few words, Minister. Thanks very much for joining us.
Thanks, Adam. This is my very first webinar, so hopefully it worked. Everything seems to be going so far okay. I'm speaking to you from my house at Royalda, where I've been operating my role as a minister now for about 3 weeks. And the only time I've actually left my property is to go to Canberra last week to pass that JobKeeper legislation. Just for those of interest, I'm actually speaking to you now via the Sky Muster satellite, and that's been my main connection for not only video but my voice as well during this time. So except for a heavy thunderstorm we had one night, it seems to be holding up okay. Look, I'd just like to first of all acknowledge the work that the Rural Doctors Association and ACRRRM are doing during this crisis. It's been very, very useful partnership between your organisations, your peak bodies that represent you all, and the government. We've certainly relied on the feedback that's come up from you through your representative bodies, and that's certainly helped formulate some of the responses, but it's also been very useful in ironing out problems. And you know, when we have such a fluid situation as we do, things are changing at a very, very rapid rate. And so there's obviously been some issues as we roll this out, and I know Dr. Nick Coatsworth is going to speak to you a little bit later tonight about the issue around PPE. but I know that's something that's been at the forefront of that's come to me through your organisation. And just out of interest, we've been hosting round tables once a week. I have here from home with all regional health representatives from doctors, allied health, Indigenous health, pharmacy, educators, quite a large, diverse group, everyone interested in regional Australia, and that's been also very, very useful in getting feedback from the ground. So, look, as you know, there's been some very, very dramatic changes that have been made, and I'm sure these are impacting on you all now on a daily basis. I think probably the first one was telehealth. We are seeing a very large uptake of telehealth. The Medicare rebate for telehealth has been doubled to accommodate the extra workload around that. There has been some confusion as to whether anyone needed to be bulk billing, and I'll stand corrected that my understanding is that obviously children, pensioners, people in that high-risk category to be bulk billed, but other billing arrangements can be organised as per normal with your practices, and we might go into that a little bit more later on. Also, I think one of the perverse situations we're in at the moment is that we are putting a lot in place, obviously, with the bulk billing. We're setting up respiratory clinics. We've got about 13 or 14 of those already operating, and negotiations are underway with GP clinics all over Australia, ultimately to end up with around 100. Some of those will be mobile, so that if we have an outbreak in a certain smaller community, there's the ability to actually move in with a relatively mobile clinic at short notice. We've also negotiated a retrieval protocol with the rural doctors and CareFlight, I believe, and I expect there'll be further announcements this week on what involved around that. But we're in a bit of a funny place at the moment, because the public have behaved well. Our rate of transmission in Australia, I think, has been quite good, particularly in regional Australia. We've had obviously some flare-ups, and there'll be, I think, the issue in Tasmania is going to be covered after I speak tonight. But what is being perverse about this is that a lot of the workload for yourselves has actually backed off, because people are not accessing regular GP services, and I think that we've probably got to do more in our messaging. I think we might have overdone the stay at home and use telehealth, and there is a concern, I know, that some people, some of your patients that have chronic issues or have critical issues that might come up unannounced to them, are showing a reluctance to actually present to your surgery or to emergency, and that indeed would be not a very desirable situation. So I think we've got to look on our messaging around that as well. And so look, I appreciate and obviously we've done a deal. The Commonwealth's done a deal with the private hospital sector to I guess prepare or conserve capacity, bed capacity, and at the moment that's also led to an underutilisation of those facilities and those staff, and that's presenting some problems. But we will work through that, and there are discussions now as to how soon can maybe elective procedures and things like that be introduced, and also discussions now at the National Cabinet level on how we're going to manage coming out of the very tight situation we are at the moment. But we are in a fairly good position, but as we can see, it can change very, very quickly. And I think our concern as a government is that people will maybe a combination of a couple of things. They'll be getting very frustrated from working from home. They'll be very financially stressed because they're away from their regular work, and in some cases their businesses are in.
It doesn't seem to be working. I can see me, but you can't. Many would say that I do have a face for radio, though, so you're probably lucky in that regard. So, Minister, just first question coming through, and we'll Minister will be hanging around for some other questions towards the end. So we'll I'll just ask this question for a start, and then we'll move through to Nick. So, Minister, with the emergence of telehealth, we've seen a few telehealth-only type services. So practices that are just doing telehealth and not really much face-to-face. And that's, of course, adding to the pressure on emergency departments and, of course, other practices in the same area. Does the government have a position on this one?
Yeah, look, I think, when things get rolled out, we've probably done what was going to be a 10-year policy changed over a couple of weeks, and so there are issues popping up. And I know there are tensions in certain communities as well, where one but as to a policy with regards to compelling practices to actually open their doors and have physical contact with patients, I'm not aware that we've got to that point yet. But I think hopefully with the change in messaging and as we progress through this initial stage, we can get that message out, because we all know that in the SARS outbreak that ravaged Asia some years ago, more people lost their lives through other illnesses that went unattended to, undiagnosed to, because of the complete focus on the SARS. We certainly don't want that to happen here. We want to make sure that we're also looking after population health. And as someone, you all represent regional Australia, and as someone, as do I, we are concerned that some of their vulnerable communities that have high levels of health issues are maybe staying away from their regular checkups, and that would be a negative. So not a direct answer to your question, but certainly all of those things as they pop up are looked at and discussed on a regular basis.
Thanks, Minister. I see from the questions we're having a little bit of trouble with different, some people are losing audio, some people are losing video. We're working to address that now. Thanks, Minister. Thanks for your time again tonight, and I'm sure you'll stay around for some questions as we move on. I might now invite Dr. Nick Coatsworth, the Deputy Chief Health Officer, to say a few words for us.
Thanks very much, and thanks for the opportunity to talk to you all tonight. And I'm just conscious that we've got a limited amount of time, so I'm going to be really brief and then just open things up to questions, because I really think that's where the money is. So just a quick bit about my background. I'm the Director of Infectious Diseases at Canberra Hospital and Health Services, or was up until about 4.5 weeks ago. And for the past 3.5 weeks have been one of Brendan Murphy's deputies, and primarily responsible for hospitals and health services, but also involved with personal protective equipment, intensive care, ventilator distribution. And some of you may know my background includes 4 years up in the top end of Australia, where I, amongst other things, was a respiratory and ID physician doing remote and regional clinics in remote Indigenous communities. So that's the background. In terms of where we are at the moment, I absolutely concur with everything that the Minister has said and won't repeat that. But I'll give you the headline numbers. I think the total number of cases is sitting at 6,400. And the important thing is that 4,109 of those are overseas acquired, and 1,586 of those are locally acquired but are known contacts. the number of patients with a contact not identified is 528. So we're sitting at just under 10%, which is in fact lower than it was last week. And as you're aware, that's one of the critical measures, because at the lower percentage that is, the less unknown transmission chains we have within the community. Those cases are overwhelmingly in major urban centres, with some notable exceptions that many of you will be aware of. Just in terms of my personal interest in ensuring that remote and regional Australia is well catered for, I've recently had discussions with one of the intensive care specialists at Alice Springs, and in conjunction with other intensive care specialists with remote and regional experience, about how we might deliver critical care. I'm one of the directors of CareFlight, so I've got a lot of understanding of that remote aeromedical retrieval piece, so I'll hopefully be able to speak to that both at a personal level and from government. And very conscious of the potential for rural and remote regions, hospitals, practices, and indeed communities to run into significant difficulty if coronavirus were to become established. I guess the good news is that the prevalence rate in the general Australian community is low. And so just to echo the Minister's comment before I open it for questions is what I have been saying in the media and to colleagues and to patients of my own is that whilst telehealth is such an important intervention of government, there are circumstances where the doctor or healthcare professional needs to see the patient face to face and interact with the patient. Flu vaccination is a great example. And people should not be staying away from healthcare facilities if they're in need of care. So we are trying to get that message out. In terms of discussions at the Australian Health Protection Principal Committee, which, as you know, is now a committee reporting directly to the National Cabinet, the discussions are well and truly underway in light of the low transmission rates and case rates regarding a reintroduction of clinical services, what that might look like and what conditions might have to be in place before we do that. And we're mainly talking, but not exclusively talking, about elective surgery there. So there are a lot of pre-prep questions, and so I'm going to stop there and just get our moderator to take us through those, and I'll answer them.
Thanks very much, Nick. Look, lots of questions coming through on the chat service. So if you want to ask a question, you go to the little blue hand icon and ask some. We've got quite a few that have come through, so we'll go through some of those. We've also got some for Nick left over from last week. So the first one, Nick, I've got a heap here, so I'm trying to group them together, but one on expansion of testing. So at the moment, many states, including Victoria, have changed their testing rules, and it's easier now to get a test. Is there a plan from the government to relax testing rules and see more people tested in the community?
So the answer to that is yes. However, it's unlikely to take the form of a wholesale relaxation of the testing guidance to enable very easy access to primary care. It's much more likely to be guided by the public health units themselves, where they will look at clusters and areas of transmission within a community, and then at a local level reorientate the testing. So, for example, the one in the media was the Bondi pop-up clinic that happened a week and a half ago, where a wide variety of patients that didn't meet the testing criteria but just had viral respiratory tract infection symptoms were being tested. And in some situations, we're doing asymptomatic patients active surveillance in small groups. But we're not going to be in a position where we have enough tests or reagents to be able to make that extremely widespread. And part of the ongoing strategy will be that the public health units within the states and territories will have control and direct that.
Thanks, Nick. Nick, question. We've had a few come through on PPE. Okay, we'll start with one on lots of practices and doctors around Australia, particularly the more remote you go, have had issues with the rollout of PPE to their practice. But do you want to make any comments on that?
Simply to say that, like you, we're hearing that in the Commonwealth Health Department, the rollout from the national stockpile is done through the PHNs, the primary health networks, and so if there are concerns about the any function of those individual PHNs, then that can certainly be channeled through to them in the first instance, and if there's further issues, then through to the national medical stockpile, so we can address that. We're absolutely keen. I mean, there could be nothing more frustrating than seeing on the media that we're saying that there's 11 million masks being distributed, but not actually seeing those get through, or not seeing them get through in sufficient quantity. So we're keen to make sure that that's as streamlined as possible.
Thanks, Nick. I've got two questions here in the situation in Tasmania, and I might throw to Eve first. Eve, how are things down in Tasmania? We've seen lots of stuff on the media today about a large number of health workers that really have to had to be put into quarantine. How are things going, and what's the biggest challenges down there in Tasmania at the moment for you, Eve?
Thanks, Adam. So obviously it's a huge cause for concern. We've got, I think 66 cases in total in the northwest, of which the majority are healthcare workers, and 2 hospitals shut. We've got healthcare workers and their entire families in quarantine, which is a total of about 5,000 people. I think today's media problems have caused an enormous amount of hurt and anger, where healthcare workers, have had this unsubstantiated story that there was a dinner party involving medical workers, and people are really hurt and upset when they're in lockdown, in quarantine, and these sort of rumours are being circulated. So that's caused a great deal of angst. I think, on the whole, in terms of the impact, obviously 2 hospitals being closed, we've seen Army being rolled in, or sort of Australian Defence personnel of whatever description coming in to assist, which is great that they're coming to help. But at a community level, obviously there's huge anxiety, and that's, understandable. And our concern as well is the possibility of rural hospitals in the surrounding area getting involved, and how well prepared they are or possibly are not to manage cases coming into their areas. We know Smithson's had issues with staffing. I'm not quite sure where their staffing's at currently, but that's been a big issue there, and they're now the sort of next hospital pretty much along the coast. So if people head that way instead, I'm not sure how well they're going to be able to cope there. Or how well prepared they've been to manage potential cases arriving there. So, yeah, it's a huge concern. Obviously, that many healthcare workers, I'm not sure if Nick is involved in, whether PPE was, I know there's been rumours in the media here that staff weren't given adequate PPE at the hospital. I've no idea if that's true or not. Hopefully it's not. And I don't know if Nick has any information on that, but certainly that's been in the media today. Here in Tasmania, so I'd be interested to hear Nick's comments on that. And certainly PPE has been an issue. We know in rural hospitals, in terms of things like especially face shields and viral filters, which we know we need to have if we're managing airways, and certainly where I work, we don't have them available currently. So that's a big concern, and people are very anxious about it. So I'll hand over to Nick to see if he has any comments, because he may know more about it.
Thanks, Eve. I really appreciate that. Make two observations. I think the first one is that the model that's being used at the moment to support Northwest Regional Hospital is the Australian Medical Assistance Teams model, where civilian AUSMAT personnel, there's 7 of them, are supporting an ADF, leading a team which is also composed of 35 clinical staff from the Australian Defence Force. That is actually it's one of the first domestic AUSMAT deployments. The previous one was in the New South Wales bushfires, but this is the first one that I can recall that's interjurisdictional. Now, this is a very important model for rural regional Australia, and it's actually the original intent of Australian medical assistance teams. You will have seen them sent overseas. That was never their original intent. It was always crafted as something within what's called ComDis Plan, or the Commonwealth Disaster Plan. So an important model obviously becomes problematic when there's multiple outbreaks in rural and regional Australia, and I'm actually having a meeting in 2 days' time with Emergency Management Australia to work through the multiple event scenario and what we could support. But for 1 or 2 events, certainly it's a good model. Just with regard and briefly to the personal protective equipment, I'm very, very conscious that healthcare worker infections are a really important signal of wider issues with infection prevention and control. It's really important that as Eve, indicated, the hurt that was caused by the rumours that were being followed today, and there are. It is an important principle of public health that rumours do get investigated. This one in particular turned out to be wrong. Was presented in an unfortunate context and has caused hurt, and we do acknowledge that. Equally, though, the assumption that a healthcare worker acquires COVID-19 because of the unavailability of PPE is often the first conclusion that we all jump to when we see that this happens. And I can tell you that that is in fact not the case in a significant number of healthcare acquired infections. So whilst it is a logical conclusion to jump to, it is not always the correct one. I've said publicly 3 days ago that I think that every healthcare worker infection requires investigation. I used formal investigation in a sort of hospital sense rather than a kind of root cause analysis type of sense. But that's my firm belief, and we've got a cell within the Commonwealth epidemiology team that's only looking at healthcare worker infections. So we'll make sure when we have concrete information out of that we share it within the profession.
Thanks for that, Nick. Thanks, Eve. Right, we'll get to as many questions as we can. And one from Sarah. One of our private labs in Victoria, ACL, is offering COVID testing from today via their private website. Patients taking a self-collected swab and sent to the pathology lab. Has there been any validation of this? Nick, have you heard of this going on, and will that potentially be used down the track? The concept of self-collecting a swab, I would have a lot of trouble with. So many of you may have had a nasopharyngeal swab done in the past, or a throat swab, and the difficulty in getting farther enough back in the nasopharynx doing it yourself, I would say, would preclude, would ruin the sensitivity of the test, which is already, at least to some degree, dependent on collector skill. Thanks, Nick. There's also a question on false negative rates. Have you got any data on the false positive, false negative rates for the current testing?
Yeah, so the PCR-based testing improves with disease duration, and so there was some early data out of China which suggested that the sensitivity is about 70%, so 30% false negatives in the first day, but that improved in intensive care setting to 100% at day 3. Again, there's variability in that depending on the adequacy of specimen collection, which is why we're getting people to do the oropharynx first. So we'll get the throat swab first and then put the swab up the nose for the nasopharyngeal swab, and that's a deliberate decision to conserve swabs, but it's just effectively a pooled sample from different sites. I guess the more important thing is the negative predictive value of the test in a low prevalence setting. So in the current Australian setting, a negative result can be, with some degree of certainty, regarded as a true negative because of the low prevalence setting.
Thanks again. So a couple of questions that are similar about the modelling for projected peak. One question from Caroline, a rumour about the COVID won't peak until potentially January, February 2021. Is this valid? And a similar question down the bottom, does the government have any modelling on regional peak and when we might see a peak in regional Australia if we cannot shut it down altogether? Nick, have you got some comments on the government's current modelling?
So beyond what we've distributed, which was for the unmitigated and partially mitigated scenarios that Brendan Murphy released last week with the Prime Minister, we don't have anything additional in terms of the current epidemic status. All that new data, that very rich data that we've got from 6,500 cases now, is being fed into the models. But keeping in mind that there's only a lower percentage of those that are truly locally acquired. So when you take away the travel cases, then you're down at about 2,000. So there's still not a great number of cases to put in to the model. I think it probably, to answer the questions, certainly the peak will be later. I've seen models saying July, I've seen models saying November, I've seen models saying February, and I think that just reflects the vagaries of modelling, but that we all agree that flattening the curve reduces the peak, enables the health service Australia-wide to cope, and then but prolongs the time with which that we have to be prepared for it, both in urban and rural regional settings and across the spectrum of the healthcare system. So that's the principle that we need to agree on. The other thing that's worth noting is the basic reproductive number, or R0, is likely to be below 1 to get the statistics that we're seeing at the moment, which is very promising. Although in some areas it'll be above 1 and get more sustained transmission in a local area before that gets shut down. The last thing to say is, yes, there is modelling of how this would spread in rural and regional Australia. I've seen that, but it's of limited use because it was in an unmitigated scenario. So you sort of saw this horrible map spreading across the country. It's not going to be like that at all. And as you might imagine, the where a case might come in to a rural regional centre, whether it's by a FIFO worker, whether it's through someone in the transport industry, whether it's porous borders with remote Indigenous communities between the Northwest, Northern Territory and the APY lands. There's a variety, so it's not possible to exactly model the spread, and probably less useful now in that we've mitigated the scenario.
Thanks very much for that. A couple of questions cutting right to the chase, Nick, about the possibility of either merely flattening the curve or are we looking at doing the same thing as New Zealand and try and eradicate or eliminate COVID with fairly aggressive lockdown and border control going on for another few months? What's the government's plan on this, and thoughts v flattening or potential for eradication and elimination in Australia?
Well, certainly it's an option. and without going too much into cabinet papers, which obviously we can't do, but it's one of several options that the AHPPC's been considering. Whether it's a realistic option, I can speak to, which I think in the sense of a continent with such geographic dispersion and a much higher population than New Zealand, I am of the view that it is not a realistic proposition to attain, but it's far more realistic to expect very low numbers. And if you like, to put it crudely, I guess it's a game of public health whack-a-mole, where you have a very robust public health units, which in fairness we do now. We've got hundreds of people in the jurisdictions, literally hundreds, who are working on this. And to give you an idea of how well it's working, the number of cases under investigation, which is a key metric for us, is actually getting smaller and smaller and smaller, suggesting that the public health units are getting better and better and better at concluding their epi investigations within 1 to 2 days. So with that in mind, if you have a robust public health architecture, you can achieve long-term suppression whilst hopefully reintroducing aspects of the healthcare system, elective surgery, and returning the economy to not some semblance of normality. Would be too early to be saying that sort of thing, but I think you get my gist there. I can tell you though that New Zealand, despite possibly being on the verge of eradication, are now wondering what on earth they're going to do, because they're worried, as we would have been if we put in stage 4 lockdown measures, of the possibility of an undetected case re-emerging and simply having to go back to stage 4. So they are by no means a panacea for how you manage COVID-19, and they are facing the same reality as everybody, which is no one's immune.
Thanks, Nick. A couple more questions just on PPE while we're on PPE before we go to the elective surgery question. At the moment, the PHNs are supplying masks to general practices. Is there any plan for them to also be able to supply the rest of the PPE, that is gowns, face shields, those sorts of things, in the near future, or GPs have to buy these themselves?
Yeah, that's a critical question. The pipeline for some of the other bits of PPE and quantities within the national stockpile are not as extensive as masks, but I was aware that was going to be a question tonight, and we're going to take that to the national stockpile and see what the distribution of gowns and face shields is likely to be through the PHN. So I'll have to take that one on notice, but aware that it's a mask is but one of several bits of the droplet precautions. The other thing to say, which is really important to reiterate, and it's as an infectious disease clinician, I by no means say this in a sort of, it's not a pejorative thing at all, but the time that we use PPE is critical, and it's the sharp end of our risk mitigation strategy that we also have the administrative controls of telehealth. Of course, we have the ability to ask our receptionists to inquire as to a patient's health when they turn up, put masks on them if they exhibit symptoms, all the things that I know your practices are doing, but just will have to be reinforced over several months, many months, if not a year. We, like hospitals, rural practices are going to have to continue exactly these workflows and models of care for the foreseeable future.
Thanks again. A question on elective surgery resuming. So is there a plan for when elective surgery might resume? will it be a blanket across the country, or will we start by regions? And is there some assurance on aerosol generating procedures that safe anaesthetist theatre protection will be in place before it resumes?
Yeah, thank you for that question. We're considering, as we speak, and we have done ever since we introduced the elective surgery sort of restrictions, at what point and what conditions there might have to be to relieve those. We're aware that many major hospitals, and I presume it's going to be the same in urban areas as regional centres and more rural areas, the hospitals are really not working at capacity at the moment. So it is certainly time to plan for that. But the things that need to be in place beforehand, and it speaks to the PPE question, we do need to be able to guarantee PPE supply. But more importantly, we have to be able to guarantee appropriate use of PPE by the workforce. And I have to stress that the prevalence of COVID-19 in any part of the Australian community, including, in my view, more densely affected areas in Sydney and Melbourne, does not justify use of N95 PPE for aerosol generating procedures in patients that have had a thorough risk assessment and in whom COVID is not suspected. So that's a really key point here, that we can't be using N95 PPE in every patient. It's not justified for every intubation. I'm aware there are some hospitals in Sydney that are actually doing that, but that is sort of cutting off our nose to spite our face. It's a false economy where we're trying to protect ourselves against a risk that isn't there now, with equipment that we may need to use in the future. So I know I'm being quite hard line on that, but the more I get into this job, the more hard line I become on that position.
Thanks, Nick. Question now, probably, I suppose I'll put to the Minister first, from Felicity, around mental health. So we're already seeing an increase in mental health presentations, etc., as people are in isolation and feeling personally and professionally isolated. What resources are available in rural remote parts of the country, and is the government got any more plans to put some more resources in rural remote areas to manage the silent killer of mental health?
Yeah, look, thanks. There's been a sort of a broad approach to this. Initially, there was $74 million that went out to not only the community, but also to provide services for health workers themselves. But some of the things that have been provided are $10 million to provide a dedicated coronavirus wellbeing support line. That's been delivered by Beyond Blue. And that's obviously, there's a lot of people suffering anxiety through financial pressures, through business closures, loss of jobs and whatever. And the $40 million will bolster the capacity of mental health support providers who have experienced an unprecedented surge in call volume. So that includes Lifeline, Kids Helpline, and others. And so I haven't got the extensive list here, but early on the government recognised that mental health, not only for the general populace, but for the workforce that are at the front line of this, really is vital. And so I'm sure the full details of that would be on the www.health.gov.au site as to exactly the full extent, but there is quite a significant investment in the mental health, mainly through the carriages that we use now.
Thanks, Minister. Probably a question next would be to John and Ewan to comment on that. News suggests today that Medicare will investigate doctors who supply telehealth services in the absence of face-to-face services across many remote practices. There's single doctor towns where GPs are trying to self-isolate due to age or chronic conditions, and it's not possible to offer a lot of face-to-face options. How will the government deal with these situations? And what John and Ewan's thoughts on this before I head to the Minister on that?
It's Ewan here. I might go first if that's okay, John.
Yes.
I think the first thing to say is that the Medicare descriptors are the descriptors, and where there's excessive use, there will obviously be the Professional Services Review Committee looking at that. So with all these things, you're looking for super users, people who are using enormous, churning through large numbers of telehealth. And we're already seeing some big corporates and some particularly chemist chains tying a GP to their phone lines. For the small rural community, I think it's clearly exceptional circumstances, and clearly there's going to be, obviously you need to do what you need to do. The thing is, though, that where you are 100% telehealth, you do need to demonstrate how you are going to arrange or what relationship you have with somebody who can examine a patient, should that be required. There needs to be just that natural linkage to somebody or some process that you have in place that will manage that person that you think really needs an examination.
Thanks, Ewan. John, have you got any comments before I throw to the Minister?
Yeah, look, we raised this early on in the piece. We could see that this was a potential risk of the rollout of wholesale telehealth. We're genuinely concerned about rural communities where there are one or two practices where one might do this and leave the burden of care on another practice, but also that rural practices in single practice towns would have no option, and it would be really unfair and inappropriate if some practices were doing this. We welcomed early the government's commitment and incentivising the doubling of the PIP-QI to ensure that there was some incentive to keep face-to-face open. So we strongly welcomed that and supported that off the bat. But, we ethically support open access to face-to-face because there will be essential care that's required face-to-face ongoing. So it's something that your RDAA has fought strongly for, and we're very happy to see ACRRR and hopefully the PSR come in behind this and make sure that people are providing appropriate medicine as per the MBS.
Thanks, John. Minister, any comments on telehealth investigation?
Look, the changes until September, this is not a permanent change. But obviously, before then, we'd be very interested in hearing back of cases where this wasn't being used in the best of intentions. And, I think there's without sounding like a Pollyanna, there's a view that in these very trying times, people will use their best endeavours to do the best by for the greater good. And if this has been abused in some way, then I think that there is an opportunity for a more immediate response from government. But I will say we are, I think back to my opening comments, we may have, done a very, very good job of encouraging people to stay at home. I think we're going to have to finesse that message so that people are feeling more comfortable about actually going to the doctor. And I know, speaking with some pharmacists, that they're in smaller communities, sometimes pharmacy is used as an alternative face-to-face discussion instead of going to the surgery. So I think we do have an issue there that we need to try and unwind. But if there's genuine outrorting on that, well, we'd certainly be looking at that and seeing what we can do.
Thanks, Minister. With the new telehealth items numbers being so well taken up, what do you think the chances are that they will be extended after September?
Look, I don't know. I think it's been an ideal response. I know that out in your organisation, ACRRRM and others, right back in the very early days of this, when we first, probably end of February, were saying that this was a good option, and I think it has been probably taken up to a greater extent than what we even thought. And so that's not a bad thing, because people are getting that advice, and quite often, the idea of people that are a little nervous about things can telehealth in and have a discussion without actually jamming up the waiting rooms at surgeries. But I think that there'll be a lot of data gathered, a lot of, anecdotal evidence gathered over this period of time, and ultimately we'll end up with a policy that's more suitable to a time when we're not dealing with a pandemic. But one of the issues when you are changing policy at record time without the normal levels of consultation and scrutiny, you end up with anomalies. But I think in the broader sense, I think that the telehealth is doing the job that it was designed to do, and a lot of people are taking benefit from it.
Thanks, Minister. Nick, a question on why not screen asymptomatic people working in healthcare and aged care in general. Have you got an answer for why we're not screening asymptomatic people?
Well, I think it's a question of where they might be. So we actually are, we as in the sort of public health community, but I guess I'm speaking in part for the jurisdictional public health units. There has been some asymptomatic screening within the clusters that have occurred in residential aged care and in down in Victoria as well. So it's a question of it is a question of bang for your buck and likelihood, I guess, pre-test probability of getting a result. So just a couple of seconds on the detail behind asymptomatic carriage. It's estimated it's probably somewhere between 5 to 10%, although there's a Diamond Princess modelling study that says 17% of cases were actually had no symptoms at all. I just caution that 17% was a modelling study, so it even though we've got the best testing or one of the best testing regimens in the world, we still have to be very targeted with how we use those tests. I think the other useful thing to say, and it responds to one of the questions online, is what do we do in Indigenous communities when we get the gene experts out there, acknowledging the high rate of suppurative lung disease and difficulty in using a syndromic case definition to determine who you test. And I think there's probably a stronger argument there for doing some active surveillance and running sputum samples through the gene expert. I mean, I'd have to leave that to Northern Territory, Queensland, New South Wales public health units to determine. South Australia, WA, well, every jurisdiction really. But it's certainly something that I will and have suggested to them that they do. So that's a short answer to a long question. I hope it suffices.
Thanks very much, Nick. Got a question on Indigenous communities. Is there a plan for what we might do if we do get a larger outbreak in Western New South Wales or southwestern Queensland to further restrict transmission and movement in and out of communities with large Indigenous populations?
Yeah, so those plans are very much being done at a jurisdictional level because they're the best placed to do that. And I acknowledge at least one of the questions raises some concerns about one jurisdiction and their ability to develop those plans. But certainly, you know, looking at the Commonwealth role, say in the Northern Territory, we're very much relying on the experience of the guys up in Darwin and Alice and those in rural and remote healthcare to implement their own plans. What we do to support, though, as the Commonwealth, has been substantial investment in RFDS and CareFlight in order to boost their capacity to take isolated patients out of community There's also been some suggestions about how you might. I heard a suggestion yesterday, which I think is a really good one. You know, if you had an outbreak in a community, would you take the elders out of that community, because that would protect them in a way. So there's a lot of interesting suggestions out there. But the principles are get the affected patients out. I think the increasing restrictions on movement would be paramount. And the third one is using structures like Australian medical assistance teams to move in. And we've taken an OSMAT into Maningrida up in the NT before. Acknowledge Dr. Leuenberg's comment about his experience with OSMAT and making sure that you've got OSMAT members who are experienced in rural and remote healthcare and not sort of fish out of waters, so to speak, from intensive care people who've never been to rural and remote. So we absolutely take that on board.
Thanks, Nick. Quick few questions before we finish off, and you can answer these quick as possible. What's happening with getting testing quicker and closer to rural areas, from Bruce?
So that's fundamentally about the gene experts. There's about 40 or 50 that have been procured by the Kirby Institute, and they're going to be rolled out into rural and remote areas. And any evidence? Sorry, for those who don't, you may be aware of the gene expert, but they'll turn around a test in about an hour and a half.
Excellent. Any evidence of mutations or different strains of the novel coronavirus?
None that are actually of clinical significance in terms of a different phenotype.
Thanks. I know we're running short of time, so I'll quickly go around the speakers before we finish off for one last big challenge or last finishing statement before we finish off. So, Mr. Coulton, thanks again for joining us. Do you want to go first?
Yeah, thanks. Look, I'll be brief. Look, I just want everyone to know that you are the eyes and ears, that you're the frontline troops on the ground. And as government, we rely on the feedback from you. We also very much appreciate the work that you're doing, and we also understand that we're in very difficult and trying conditions for a whole range of reasons. And so through your associations, whether it's RDAA or ACRRRM, feed that information back through, because it's very useful for our response. And as we've seen through the discussion tonight, we do need to be fluid. We do need to be able to be flexible in what we do, and we have the ability to change that quite quickly. So thank you for your time tonight, and thank you for the work you're doing.
Thanks, Minister. Thanks for joining us. Nick, again, busy time for a Deputy Chief Medical Officer, and I really appreciate you taking the time to join us. Any last comments before we close out?
Well, firstly, I really enjoyed being part of this. The CMO's office will support these webinars, absolutely, and I'm taking away all of those PPE items to get resolved as to the best we can. So thank you.
Thanks, Nick. Eve, down in Tasmania there, putting in the hard yards rurally. Any last comments?
Yeah, I think the main thing from here is we'd really like to see whatever learnings come out of the Northwest disseminated as far as possible, so that everyone can take away lessons from that, and what happens there can inform other people. And also, that rural hospitals, we need to be as well prepared as we possibly can be for when this starts to get out into rural areas more and more, and we start to see more cases, that we're as well prepared as we can be in terms of training, PPE, equipment, doing scenarios, running through what we're doing, so that we can be as well prepared as we can, because, it could well be coming.
Thanks, Eve. ACRRRM President, Dr. Ewan McPhee.
Thanks very much, Adam. Look, I've nothing to say. Really enjoyed tonight, and thank you, Minister and Nick, for your excellent presentations. Just to advise people that the college is working very closely with government. We have enjoyed premium access since the onset of this emergency, and we're very grateful for it. But if people have any suggestions or anything they would like us to address, please contact us through the President. Thank you.
Thanks, Ewan. Dr. John Hall from RDAA.
Thanks, Adam, and thanks to the Minister and to Nick and the panel for a great webinar tonight. I just want to reiterate what I said last week. I want to thank all of you for the hard work that you're doing out on the coalface, acknowledging that it's a very stressful time for everyone, for you and your family. So thank you for all your hard work and keep up the good work. I want to echo what Eve said. Really, this is our big policy push this week, is the concern around rural hospital preparedness. We've had a number of reports from rural hospitals that don't have enough stock, don't have enough PPE and feel underprepared, and we're going to be pushing hard to make sure that all states support their hospitals, support their jurisdictions in this area, and we've written to all state health ministers along those lines. So make sure you let us know if you're having any issues. We're happy to go into bat. Thanks again for joining tonight, and I really enjoyed it, and looking forward to catching up again next week.
Thanks, John. Thanks to everyone who participated, and a big thank you to our panel. Very good turnout tonight, and we really appreciate everyone taking the time to join us. Please check out our COVID-19 bulletin. It'll be out in the morning, and you can relive this great event with a recording which will be available on our website. Please complete our evaluation. It'll be emailed to you. We're taking on your feedback from our last webinar and have tried to incorporate it into this one. Suggested resources will be available on our that we can develop through our COVID project. Will be available on the RDAA and ACRRRM websites. Registrations will soon be open for next Tuesday's webinar on the discussion of the importance of teams with National Rural Health Commissioner Dr. Paul Worley and some others joining us again tonight. Thanks, everyone. Thanks for joining. We will get to address as many of your questions as possible and try and put them into our bulletins. But that's it from us. And thank you very much for participating. And keep an eye out for our COVID-19 bulletin coming out tomorrow. Thank you, everyone. Good night. Stay safe.